Our next speaker is Dr. Mohammad Numair Younis. He is a consultant nuclear physician and is a co-founder of Younis Bashir Award under American College of Nuclear Medicine. He is an approved CPSP supervisor for postgraduate training of FCPS Nuclear Medicine, part of faculty of PIAS between 2001 to 2007, and visiting faculty of University of Health Sciences, Lahore from 2004 till date. He is pioneer in clinical applications of theranostic nuclear medicine in Pakistan and ambassador of Pakistan as European Society of Hybrid Imaging. His topic of presentation is PET-CT in abdominal malignancies. Dr. Numair, please take over.
Thank you very much, Dr. Saima, for inviting me. आपने इतनी सारी बातें बता दी, इनमें से बहुत सारी मैं खुद भी भूल गया हूँ कि ये मैंने किया हुआ है. But thank you anyway. So, my talk will be about PET-CT in abdominal malignancies, and since the topic covers a lot of malignancies which arise from different organs in the abdomen, I would be focusing more towards the one that has been approved by the clinical guidelines, touching upon a few of the novel radiotracers in abdominal malignancies. So here we can see that FDG PET, which has been used in use for many years and is identified as one of the most approved clinical guideline application for abdominal malignancies. We will be touching upon the use of dotatate, PSNM and FAPI as well, but I won't be talking much about these in this talk today. So we all know that the glucose is taken up by the tumor cells. So there was an idea of developing FDG, which can be labeled with a positron emitter, which is F18. So the deoxyglucose was developed, and this is concentrated by the tumor cells in a high quantity. So there is a very rich signal coming from the tumor cells that helps us to identify the tumors from the benign and the physiological uptake. So that's how the FDG got its approval for many applications, including staging, restaging, response evaluation, surveillance, and detection of recurrence as well. So the story for the abdominal malignancies, including the GIT malignancies, is similar. It's been used for esophageal, gastric, bowel, hepatic, pancreatic, anal canal cancers, and many others. So we'll see what are the limitations and how it helps us. But before we go into that, we need to remember that, sorry, I have a bad throat. So we need to remember that this FDG will be taken up by the normal cells in the intestine and the gastric mucosa as well. So there are certain reasons for which the false positivity of FDG is actually blocking or hampering the routine use of FDG PET-CT in many clinical applications. We need to understand that here we might need to use the oral contrast as well as the IV contrast if we want to delineate the pathologies within the GIT, as well as to understand the pathologies which are in close association with the GI tract within the abdomen. Similarly, if the patient is on oral hypoglycemic such as metformin, even if the patient is not going to receive contrast, the uptake of the FDG will be higher in the intestinal tract, and that will mask many malignancies and pathologies in this. So this is important to remember before we can ask the patient to come for FDG PET scan. Now these are the patterns. We can see that there can be a focal uptake of FDG, which can be simple physiological uptake. Then there can be a diffuse uptake throughout the small intestine or the large intestine. Then a segment of gut may show intense uptake. And sometimes you see mild diffuse activity in the stomach, or sometimes a focal uptake in the stomach. All these can be benign physiological conditions, and they may mimic as a case of tumor as well. So for esophageal and GE junction tumors, we need to remember that the many clinical guidelines, they do not recommend this FDG PET-CT to be used as an initial staging tool. Although both squamous cell carcinoma and adenocarcinoma, they show high FDG avidity, and they have found out that during the surgery, they found out that more than 60% or up to 60% of the cases, they may show nodal metastasis, even though they were not evident on routine imaging. So there is a case for FDG PET-CT to be used for prior to surgery in patients of esophageal cancer. However, false negative FDG PET-CT is also seen because many small lesions will not show up on FDG PET scan, as well as some mucinous producing esophageal carcinomas will not be evident on FDG PET scan. Similarly, small lymph nodes which are in close proximity of the primary tumor, they will not show uptake, or they may be masked by the uptake within the esophageal carcinoma. So they may be missed on the FDG PET-CT scan. So most of the clinical guidelines, they recommend the use of FDG PET-CT for the identification of distant metastasis, not the regional or the primary tumor, because the T staging is not that clear on PET-CT scan. Then for tumor response evaluation before the patient goes for curative surgery. And in those patients who are unresectable and undergoing chemoradiation for debulking, again, a PET-CT can be used. So there we can see the two cases, intense uptake in the primary tumor, and another case here which is being showing two cases, two time points in the imaging of the same case. One is with the high uptake of FDG within the primary tumor followed by chemotherapy, and we can see minimal uptake is left in the GE junction tumor. So the novel applications which has been suggested for the esophageal carcinoma, I have found out two interesting studies to share today. So they have found out that if FDG PET-CT is used for the treatment planning before radiotherapy, actually it can prevent underdosing and ineffective treatment, particularly in patients who are receiving chemoradiation or radiotherapy as a definitive treatment before surgery, or in cases of incurable surgical patients. For gastric cancer, unfortunately, FDG PET scan is not recommended because, not routinely recommended, because the uptake of FDG is variable, and many of these tumors, especially the signet ring cell subtype, it loses the possibility of concentrating FDG because of downregulation of GLUT1 receptors in these cases. Also, the mucinous secreting tumors, they will not show uptake. So there will be a lot of false negative, even though the tumor is visible on the CT part of the PET-CT scan. Again, a false positive can happen because many conditions within the stomach, they can show intense uptake like gastritis or a presence of polyp. So in both ways, the false positivity and false negativity hampers the use of FDG PET scan as a routine study. So the clinical guidelines, mostly they recommend it to be used when there is a high clinical suspicion of metastatic disease. So preoperative assessment can include FDG PET-CT, and in other patients who have received chemoradiotherapy, again for response evaluation, FDG PET-CT can be used. GIST are rare tumors. They are solid tumors. They can occur in the stomach or outside the stomach within the intestinal tract. They have a range from benign to malignant, and the malignant potential can be identified using FDG PET-CT, which is showing high or intense uptake on the PET scan. So whenever the PET scan is used, it has certain advantages. It can identify the malignant potential, one, and it can also identify the sites outside the stomach, maybe within the small intestine or the large intestine, occurring simultaneously as a part of GIST complex. Then the nodal and hepatic metastasis can be identified because of their high FDG uptake. A very recent study has also shown that in patients who are inoperable and are a candidate for TKI, here the FDG PET scan can be used for response assessment. Actually, for until now, the response assessment for the GIST tumor is either through RECIST criteria or they use the Choi criteria for response assessment. Both are the depending on the morphological features, on the density and the size. So here, this study has shown that if there is a reduction of more than 40% in the tumor uptake, it shows good response and also give prognostic information. In HCC, FDG PET-CT scan has shown poor performance, especially in well differentiated or moderately differentiated HCC. On the other hand, poorly differentiated HCC, because of high GLUT receptor expression and loss of glucose 6-phosphatase activity, it concentrates FDG in higher amounts and shows a higher signal. So FDG PET scan can be used to detect the HCC and for its staging. Right now, the only use for FDG PET CT in HCC is recommended pre-transplant when they want to exclude extrahepatic disease, especially nodal and distant metastasis. Otherwise, FDG PET scan is not routinely recommended. However, in our own experience, we have found that in our patients, this study was published recently and it included 51 patients. We performed PET scan in 51 consecutive patients, and we found out that more than 80% of these patients, they showed positivity. So the sensitivity of FDG PET CT in our population is high, and probably because the disease is either poorly differentiated or multifocal, so it shows higher uptake as compared to the documented in literature. Another study which we recently published also shows a relationship between the high SUV values and the presence of tumor burden. So this SUV values can be used not only to predict the presence of metastasis, but it can also be used for the prognostic information in these patients. PSMA has been used for the detection of HCC and for the detection of recurrence because HCC has a very high expression of PSMA receptors. So this can be targeted by using gallium or F18 labeled PSMA, and we can detect either the primary tumor or the recurrence. So here the case on the left side is actually showing a recurrence on the periphery of a treated HCC, and on the right side there is an exophytic mass which is arising from the left hepatic lobe, and it's showing high PSMA avidity. A very recently published paper actually has utilized this high PSMA expression and has suggested that lutetium PSMA can be used as a therapeutic measure for these patients who actually are unresectable and they do not respond to usual microwave ablation or local targeted therapies. In those patients, lutetium PSMA can be a viable option for the treatment of metastatic or primary HCC. Cholangiocarcinoma, on the other hand, is a tumor which arises from the biliary tract. It's mostly adenocarcinoma and it shows high avidity, but there is lack of evidence in the literature to support the routine use of FDG PET CT in cholangiocarcinoma. Similarly, gallbladder carcinoma is also more than 90% cases is adenocarcinoma, and it also shows very high FDG avidity. We found some literature published articles which support the use of FDG PET CT, but clinical guidelines, they do not recommend the routine use of FDG PET CT, neither in staging nor in restaging or response evaluation. So more studies are required to establish the role of FDG PET CT in gallbladder and cholangiocarcinoma. For pancreatic carcinoma, most of the clinical guidelines, they recommend the use of endoscopic ultrasound, CT and MRI to identify the resectability and to identify the distant metastasis. The only indication for FDG PET CT in pancreatic carcinoma is patients who are a candidate for surgery, but they are considered high risk because of either very severe symptoms or very high tumor markers. So there is a chance that they have metastasis. Just to exclude the presence of distant metastasis, FDG PET CT can be used. Although FDG PET shows a high uptake in the pancreatic tumor most of the time, but it can show false positive result because of associated pancreatitis with the primary tumor will also show uptake. So it may be a unifocal disease on CT or MRI, but it may appear a multifocal disease false positively on FDG PET scan. So this is our case. We did use FAPI in 2021. This is a case of pancreatic carcinoma recurrence. Patient had received radiotherapy and was followed up on CT, which was unable to detect this recurrence. We found out that there was an intense uptake of FAPI in the primary site, and there was metastatic disease in the adjacent lymph nodes as well as in the hepatic lesions. So a FAPI is maybe the new radiopharmaceutical that can be used for the pancreatic, for GI cancers, as already talked about by Dr. Arzu here, and she has already shown some therapeutic potential for the use of FAPI as well. For intestinal large gut and small gut, as well as rectum and anal canal tumors, FDG PET scan has been recommended for use when there is a high suspicion of recurrence, and either because of rising tumor marker levels, or there are certain morphological evidence which cannot be characterized on the routine investigations. So there may be some slight increase in the size, or there may be some contrast enhancement seen on the CT, ultrasound, or MRI, but it's still not fully understood that whether the recurrence is there or not. So FDG PET CT in these cases is very useful for the detection of recurrence earlier during the course of the disease. This is a very good study which has shown that the different stages of intestinal carcinoma, they have picked up on FDG PET CT. They underwent resection, and histopathological correlation was done, and they have shown more than 90% sensitivity and a very high specificity if a proper standardized protocol is used for taking up FDG PET scan in these patients. This is just to show that the high uptake of FDG can be used when there is a standardized protocol using oral contrast for the intestinal carcinoma evaluation. Radiotherapy planning based on FDG PET CT is another application where FDG scan can be used. And this is a case which has been reported in the literature, and they have found out that this anal carcinoma, which was unresectable, it did show another lymph node adjacent to it, which was missed on CT and MRI, and it showed high uptake. So it was included in the radiation field. So this case again shows the importance of FDG PET scan for the treatment planning. Although in treatment planning, still we lack the evidence, and there is more data still required for routine use recommendation. This is a case of gastroenteropancreatic neuroendocrine tumor, and here we can use DOTA-TATE PET scan, which has been recommended as by the many clinical guidelines now. Just on your right side is the FDG PET scan in the same patient who has shown progression on 2 consecutive DOTA-TATE PET scans. So in this patient, the FDG uptake is also found in the tumor cells in the primary site as well as the metastatic sites. So a use of neuroendocrine, in particularly neuroendocrine tumors, where G3 disease is suspected, grade 3 is histological evidence, or the behavior of the disease is like that it has undergone a transformation from G1, G2 to G3. A combination of DOTA-TATE and FDG has been recommended to select the patient for PRRT. Very recently, CXCR4, which is a chemokine receptor target, it's also been utilized for PET CT scanning in these patients, and this CXCR4 is a target which is present in the tumor cells in many diseases, including pancreatic as well as GI cancers. So this is a case which is showing on the left side a high uptake of CXCR4, which is labeled with gallium-68. On the right side, there is a tumor which is not showing this presence of this tumor, so it is not showing any uptake in the primary site. So malignant peritoneal mesothelioma is also a very rare disease, but it's part of the abdominal disease, and it is found that whenever there is an asbestos exposure, there is a risk of pleural and peritoneal mesothelioma. In cases of peritoneal mesothelioma, they have found out that up to 1/3 of the patients, they do give history of asbestos exposure. CT findings are not specific to identify peritoneal mesothelioma. FDG PET CT, on the other hand, may show very high uptake. We have also published a case report of showing high FDG uptake in patients of malignant peritoneal mesothelioma. A study also recommends that the FDG PET scan can be used for the detection of recurrence earlier after curative treatment. So because of very high signal coming from the tumor sites or the recurrent sites, we can pick the disease earlier on, even before the CT or MR can pick the disease. So I just conclude my talk today that the abdominal malignancies can be evaluated using PET-CT, but not all the abdominal malignancies will be picked up, and it's based on the site of the disease. T-staging is usually not possible to evaluate fully on PET-CT scan alone. Many times endoscopic ultrasound or MRI is recommended rather than PET-CT. So newer targets which are not utilizing the metabolic profile, but they are more focused on the receptors and the different targets within the tumor cells, they would be rather leading the way towards utilization of PET-CT in the abdominal tumors. Thank you very much, and with this I thank the scientific committee, the organizing committee, the president of the PSNM for inviting me and giving me this opportunity to present my talk here, and thank you very much.